You're listening to BODYWISE. I'm Matt.
And I'm Ciara.
Ciara, what's BODYWISE all about?
I was going to ask you this week.
I'm Matt, I'm a GP and Ciara's a nurse, and we talk about issues that we think are important with maybe a more relaxed and open-minded stance than normal.
Excellent.
Is that fair enough?
Yeah.
And what are we going to talk about today?
Oh, we're going to talk about dementia. Another tough topic. So last week we talked about depression and that was a hard one, wasn't it? You know?
Yeah, it's a difficult topic.
And dementia is a difficult topic too, because lots of people have been affected by dementia. They've had a family member who's had dementia. And for a lot of people, it's been a very difficult time as they've watched someone that they love maybe change from how they used to be.
I've had several relatives who had dementia, and one of the things that I would always say to patients or family members when they come into me is that patients who have dementia generally don't know that they have dementia, and I don't think using the term suffering from dementia is actually appropriate, because people from dementia don't suffer from dementia. It tends to be their relatives. I often think that dementia is one condition where you're treating the patient but also their family, particularly their partner, and that the partner and the family needs a huge amount of support, because it is, and it can be at times, very difficult.
One of the professionals that we're going to talk to in this episode is going to mention the Northern Wellbeing Centre, and I know that that's been a really great resource for families of people with dementia. Can you explain a bit about the wellness centres that we've got around the island?
So this is a relatively new thing. Certainly in my experience in Ramsey, the Northern Wellbeing Partnership is up and running since January. Basically, it's a really good idea. So all of those supports in the community have come together under one umbrella called the Northern Wellbeing Partnership. And the idea is that when I as a doctor, when you as a nurse, or when a member of the community reaches out looking for help, whether that's the help of a district nurse, or maybe they don't know what help they need, but they have a particular problem. For example, it could be that they're having difficulty with their memory, or they need more help. That issue that the person is having is dealt with by a group of people who decide exactly what supports you need. So it's kind of a one-stop shop for support that only really existed up until now. Before that, what used to happen is I as a doctor and you as a nurse used to reach out to the district nurse or the physio, but now actually they've got a one-stop shop, and they might say, actually, Ciara, this person needs to see more than an occupational therapist. You know, they're also suffering from loneliness, and we'll bring in someone in the third sector. So I think it's a really good development for the Isle of Man.
I totally agree. And I know for me, I'll often see people who are carers who are really struggling and getting very limited support, maybe really struggling to get any respite for a loved one. And actually the wellbeing centres have been fantastic at putting them in some directions of not only Manx care related things, but like you said, third sector stuff. We've got an amazing Northern Men in Sheds, and I know there's more than just the Northern one, but they can be fantastic for loneliness, for meeting new people and learning new skills. And then there's more, isn't there, outside of that as well? There
is. So what we're going to do now is, I suppose the format for the programme has been that we tend to talk to an expert in the resident field who randomly is from Ireland, bizarrely enough, and we put a few questions to them. And our expert this evening is Dr. Joe Brown, and he works in the largest hospital in Ireland, and the largest centre for memory in the country. So I think it's going to be interesting to hear his perspective.
Yes, let's.
And the reason we've asked Joe to come into us today is, number one, he's Irish, obviously, and I'm super biased. But number two is I've worked with Joe, and I continue to work with Joe, and Joe knows his stuff, Ciara.
I think you work with everyone. Hi, Joe.
Hi, good afternoon or good evening to you both.
Hello, thank you so much for joining us.
So one of the things we wanted to talk about today, Joe, which is obviously the most obvious question, is probably what everyone is asking, but what is dementia? Ciara, is that a fair question to open with?
For sure. And also, is dementia Alzheimer's, and is Alzheimer's dementia? I get that one quite a bit.
Oh, so they're hard questions. Number one, dementia can present in different ways. So dementia is it can be either memory loss, it can be problems with concentrating. It may be something to do with where somebody's not familiar or not doing their daily tasks as good as they should, whether it be shopping or paying the bills as normally, and sometimes they're struggling to follow conversations or being okay occasionally confused, or there's mood changes. Depending on the type of dementia. So there's many types of dementia. So Alzheimer's is probably the one that everyone knows about. It typically is the one that where people will have problems regarding memory, particularly knowing somebody or recognizing a face, or they're kind of repetitively asking questions, and they're just finding new tasks. So giving them, let's say remote control for a TV, they find that really, really hard. And sometimes they find really the right words to say. Now, there are other types of dementia. One of them is vascular dementia, which is something you see with people who might have strokes. There are some unusual types of dementia, some associated with Parkinson's disease called Lewy body type dementia. There's some that affect your frontal lobes, which are kind of the areas that kind of control your personality. So therefore, these people might have altered sensitivity around other people's feelings. They sometimes might become very cold on feeling. Lack of social awareness, so they start being disinhibited. Sometimes they might have language problems. And then there's kind of a group that don't necessarily fall into one particular group. They can be a gradual decline over time, and they might more manifest as more behavioral changes and things like that. So it's very hard to kind of. I think Alzheimer's is probably the more common one you see or hear about, but there's many types.
When I have patients coming into me, there seems to be two different types of presentation. There's people who notice something wrong with them and want to deal with it straight away, and then there's other people that might sit on a problem for a long time because they're not ready to discuss it, or they hope it goes away, or they're frightened of it. And often in the cases of dementia, I've noticed that people seem to present a little further down the line. They've wanted to keep it to themselves, they're worried, they're frightened, and they present late on. And I wanted to ask you, what difference would it make to somebody's pathway, if any difference, if they came and presented to their GP with memory problems at an early stage?
So the first thing I'd be kind of wondering is it genuinely a memory problem, or is it an underlying, sometimes what we see is maybe there's some other medical condition going on. So presenting to GP is probably a good thing to have that assessed. So we often see people with, let's say, thyroid disorders or underlying problems with their blood counts and things like that, presenting in a very unusual type of way with memory loss or concentration. Typically, let's say you're hypothyroid, you might have, let's say, problems in concentrating and things like that. You might be a bit more sleepy. Another group might be people who have chronic obstructive airways disease, who kind of have sleep apnea. So they would often kind of present with kind of a fogginess of the brain, not able to concentrate as well as they used to. And often they're presenting with a memory problem, but not necessarily dementia. They're presenting, their fear is dementia, and there can be an anxiety behind that as well. So sometimes addressing the underlying medical reason in some cases can be enough. Some things are very easy to treat, whether it be, let's say, a thyroid disorder, sleep apnea less so. You might need to have that properly investigated. And sometimes somebody, let's say, if it's anemia or some other conditions, they can be also addressed either from a medical clinic or in a GP practice as well. So the first thing I'd probably say to most patients is probably make sure there is no other underlying medical reason for why they're feeling the memory isn't as good as it used to be. Sometimes people do get overly worked up over their memory. Sometimes it can be, often people can be just absent-minded, which is kind of a common trait, and actually more intelligent people tend to be absent-minded. So therefore anxiety can play into this kind of memory problem as well. So again, you might see this somebody who's very stressed in a very kind of high pressure job. They're not thinking as well as they would normally, and sometimes dealing with that anxiety and stress can be enough to get over the memory problem. Often it is hard sometimes to make a diagnosis of dementia, and often there can be symptoms preceding up to many years before they actually come to presentation. So we typically would see people in the hospital. I'll be sort of a bias and say that we have actually probably seen them a bit more advanced than, let's say, in general practice, who probably had symptoms going on for 2 or 3 years. And it's only when you talk to relatives or the patient say, oh yeah, that, I did have problems with my memory there, or there was a behavioral change noticed. So sometimes people are not aware that they have a memory problem until it's probably later on. But that doesn't mean there isn't a treatment or treatments available for some of these people.
And what I'm hearing is that dementia is complex, and it sounds like there's lots of different kinds of dementia. But basically, what people need to know about dementia is that dementia is a problem with your memory, And that's really all that you need to worry about. It's up for the doctors to figure out what kind of dementia that you have and where we go from there. Would that be kind of a fair overall assessment?
Yeah, I think it's very fair, and I think sometimes some memory problems are reversible. So it's not a case of that this is going to progress. Some people, once they have the underlying condition looked at and addressed, it can actually reverse. So that's probably the more encouraging side of it.
I think
as well.
that's really interesting, because I think a lot of people do think, oh, this is me now.
But another one we'd see a lot of in general practice, Joe, is depression, where people or family members are brought in because there is a problem with their memory, and actually what they have is a severe form of depression, which is something that we would see, I'm not saying very often, but often in general practice. And there's just a lot of different things that can affect your memory, and it's not always dementia.
And that's true. I mean, one of the concerns we have is pseudodementia. So that's what Matt is describing. There are more people who do present with a depressive-like episode. It may be lingering for many, many months, and no one really has kind of diagnosed it. And often they come to attention when it's more profound and at that point as well. Some people don't realize they're depressed, and often it's only when it's brought to the GP or the practitioner's attention, then they kind of admit to that they have an issue. So sometimes it's just a kind of, who do you talk to, or who do you trust to talk to if you've got a memory problem? It's quite intimidating to say that you might have a memory problem.
One of the questions I wanted to ask you is, when I was in college, which was hundreds of years ago, one of the things they told us is that people who have dementia don't come to the doctor thinking they have dementia, that it's really unusual for somebody who has dementia to actually realise that it tends to be loved ones or people around you. Has that school of thought changed?
I think some of the awareness programs have helped people be a bit more open about themselves. I think in general, you're right, that some people, it's really the relatives that pick it up more quicker than the actual person who has the underlying memory problem. But I think people now feel as though, because there's avenues and there's things you can do, whether it be planning for the future, with the treatments that may be available, people are a bit more upfront about it. Years ago, certainly in Ireland, it was very much something where it was actually suppressed. There was almost kind of a segregation of older people with memory problems, and almost like they were almost kept out of sight. I think that's kind of changed from now, although some people are frightened of being segregated again from their family if they do have memory problems.
And let's say someone, so often what we find in general practice is we would meet the patient or meet their family and say, yes, there's definitely potentially a memory problem here. And then that's really where the general practitioners would hand over to experts like yourselves. And then in terms of, would you be able to outline to us kind of what that pathway looks like? So I know one of the big steps is they're seen by occupational therapy, and they do these kind of complex memory tests. What then happens? You guys then, I suppose, are given the results of these tests, and what happens after that?
So, for example, if somebody's referred to my clinic, often the standard test will be to kind of do a memory test. So a lot of people hear things like an MSc or a MOCA or something like that.
Yep.
Depending on, so some people with memory problems are not as straightforward. There's much more advanced memory tests you can do in a clinic, but they do take time. So often in a clinic, you may only have about 20 minutes to assess somebody, and you might want to refer them on to a more specialized clinic where it might take a little bit longer. And that's where the occupational therapist, the psychologist gets involved. They kind of cover a lot of grounds, whether it's an underlying organic problem, so whether it be like underlying stroke disease, or is it something like depression, as we said earlier on, or is there something else going on where it's affecting their task? So that's where an occupational therapist can be very useful, that they can give them routines that can improve their memory, but also it also demonstrates to them if they're able to do certain tasks or learn new tasks as well. Sometimes what we find with people with memory problems, there might be other conditions that can be rectified. So they might have issues around their falls or mobility and things like that, where we sometimes do get our physiotherapists involved as well. So sometimes you might find somebody with maybe a vascular dementia might have had underlying strokes and may have already had problems with mobility. So we try and kind of do a multi kind of team assessment. So what we do now, call it in the geriatric world now, is comprehensive geriatric assessment, where it isn't just the medical problems. We look at kind of the kind of social work side of it, the occupational therapist, the physiotherapist, nutrition, and all the things that do make up an individual, a much more holistic approach to a patient rather than just the medical reasons.
Got you. So it's much more than just medicating somebody to help them along their pathway. What kind of treatments are available for people who've been diagnosed with dementia?
So in terms of just taken from the medical side of it, often it's more kind of more healthy lifestyle. So often if they've had high blood pressure, let's say you're talking about somebody who's got vascular dementia, things like correcting their cholesterol, high blood pressure, sometimes there is the use of some medication that might enhance memory, but again, that's controversial in some areas of the world as well. There are basic things people can do. So in terms of exercise, so exercise seems to have improve not necessarily memory, but also social interaction. So being able to get out, being independent are all good things. Trying to maintain somebody's independence as long as we can is probably the way to go. There are other legal implications. Sometimes if we felt that somebody's memory is declining, we might advise them regarding how to plan for the future. So in Ireland, we have power of attorney, or an enduring power of attorney, where people can plan and think what would happen in 5 or 10 or 15 years if something happened to you. It's very much like trying to do for want of a better phrase, a living will. So if you had property, what would you want done with that property if you weren't able to manage it? And then in terms of kind of more practical things in the house, so there's a lot of things people can do in terms of telemedicine, whether setting up monitors in the house, whether it be pendant alarms, reminders. So, and then they will be probably more useful in more moderate cases of dementia. Unfortunately, when you get to more latter end of dementia, some of these things are quite hard to learn and can be quite confusing for somebody and irritating in some cases. So they may not always be useful in some people, some of the telemedicine avenues in, but they are very useful in people who might need prompting or might need help, kind of reminding them of certain things or appointments and things like that.
And I just wanted to ask one more question. So from a nursing point of view, when I trained, which was even longer ago than when Matt trained, we were always told reorientate, and it was such a heartbreaking process a lot of the time to have to let somebody know that someone that was really important to them had died several times a day. Is that still what we do?
To a certain extent, but I try. So the way I look at people with dementia is like going into a filing cabinet. You don't know which part of the filing cabinet has been opened up. So I kind of, if they feel as though they're very sad that day, I try and address that issue, why are you sad that day, and try and kind of go around and almost, it's not necessarily acting, but it's just kind of being in their position. If they're in a very angry final phase, well, then you're trying to decompress that a little bit. So often it's very much how they're behaving on the day themselves and what are they feeling, and you're trying to diffuse situations. So I think the reorientation, yes, it is useful, but sometimes that might cause more frustration and anger in the patient. That's what I would normally find. So often when I'm on the ward, I try and work out what has upset them or irritated them and then try and work around that as best I can. And often we would often give a patient tasks, and some of the things we do on wards now are either kind of pastimes. Sometimes music therapy can be very helpful. I've seen massage therapy of hands being quite useful in some patients in the NHS where I worked in Leicester as well. So there are different avenues in controlling or some of the emotions that somebody has. Sometimes they just don't have control or very good control over their emotions when they've got more moderate to severe dementia.
So it sounds like, to summarize our conversation, Joe, basically, like, so dementia is where you have memory problems. The first step would be to go to see your GP or your practice nurse. And then what happens after that is, I suppose, the team in the hospital will assess your memory, and then there are various treatment options available there. I mean, would that be a fair summary of our conversation? Would there be any kind of other kind of tips or recommendations that you feel myself and Ciara should have asked you, or things that you would say would be good from a protective perspective from your health? So you said exercise, a healthy balanced diet. There are two things that you can do to protect your memory going forward.
So I think other things is everything in moderation. So smoking, if you look at pure stroke disease and stroke prevention, smoking is probably a no. Alcohol in moderation, not excessive alcohol. In terms of a healthy lifestyle, exercising, social interactions, trying to kind of interact with more people can be a good thing, and also keeps your network of connections as well. And also trying to, in some way, try to be as independent as you can. So if you do find that your memories decline, then probably have that reasonable conversation with the rest of your family about how to plan for this for the future. Often people can do these things in advance and be able to kind of put out their own wishes for that eventuality if it does happen.
That's been really enlightening. I'm really glad that we could speak to you today. So thank you so much for giving us your time. It's fantastic.
No problem. Very welcome. Thank you very much.
So that was Dr. Brown's perspective, and it's always really interesting, I suppose, from our perspective in primary care to get the perspective of our hospital colleagues, because what we see is often very different and possibly at a different stage to what they're used to dealing with.
Yeah, of course, yeah. And being able to talk to someone who's dedicated so many years of their life to that area is awesome, isn't it?
And one of the things you've done, Ciara, as part of this series is to really talk to people who either are suffering from the condition themselves or people who work in the field. And who are we going to talk to this time around?
We're going to talk to Emily Hignett. Emily is she's a mental health nurse, and she works in older people's mental health.
Okay, that's going to be a really interesting perspective. So we'll listen to Emily now.
Emily, can you tell me a little bit about your role, what you do?
Of course I can, Ciara. So I am a registered mental health nurse. I work for as you said, the Older Persons Mental Health Service, and we are the memory clinic, where we have the memory clinic, and we also help people with things like anxiety, depression over the age of 65. Obviously, the kind of relevant thing today, and a big part of our job is the memory service. So we help people at home who have memory problems. We do assessments with them. We refer them on to other services that can offer support and guidance. And we generally just try and keep people plodding along at home as well as they can for as long as they can. We do have an older population on Ireland, and a big part of our role is dementia and is helping people with memory problems. And as I said, on the back of COVID, we've definitely seen an increase just because people have been so isolated and not being able to have that support from family and friends like they used to. We've seen a big increase in terms of people with memory problems. So
in your role, when you meet someone for the first time who has a dementia problem, when they present to you, how do you go about helping them and assessing them?
Okay, so obviously we get the referrals from the GP. We have two meetings a week where we discuss all of our initial referrals and what we think is the best pathway for them. If someone is referred to memory clinic and we think an initial memory assessment is what's appropriate for them, then what that looks like, the memory clinic process is kind of mainly three appointments. So the initial appointment is where we pop out and meet the person at home. It could be at home, it could be at our base down in Douglas. And we generally, we have a chat about what their opinion of it is, because a lot of the time people don't think they've got a memory problem, and it's usually family members or friends that have kind of flagged it up with the GP. But we have a chat about what we think is going on, how they function at home, what their interests are, what keeps them stimulated or not, as COVID has shown us. But we just have a chat generally about that person's view of what's going on, and if they think they've got a memory problem, we do a quick memory test, and we look at people's mood and things as well, because that can have an impact on their memory, and quite often that kind of goes hand in hand. Obviously, if people are starting to notice that they've got memory problems, it can be quite a daunting realisation in older age, and can be quite intimidating in a way. So we try and be as holistic as we can and look at that as part of our initial assessment process. From that, if we decide that we're going ahead with memory clinic, we ask for an appointment with one of our consultant psychiatrists, which is what we call the diagnosis appointment, which is where we discuss all the memory tests and the brain scan that we ask for. Obviously, prior to that, we do some more cognitive assessments, which again people usually dread and say, I've not revised for this, but it's not that bad. We try and make it as kind of light-hearted as we can, and make it more of a general chit-chat than formal assessment, because it is quite intimidating. And then, as I said, from that, in the final appointment with the doctor, we look at all the assessments that we do together. We review the brain scan that we ask for, and then we kind of have a general chit-chat about if we think there's a memory problem, what we think is causing it, and anything that may be able to help in terms of medications and things like that.
So when you have someone who's been diagnosed with dementia, what can your team do to improve their situation?
Okay. So in terms of quality of life, I think that there's a massive misconception that people who have received a diagnosis of dementia, it's a kind of done deal. That's that, that's not true, obviously. I often say to people, the reason why we do what we do is to try and keep people living at home as independently as they can for as long as they can. There quite often are certain medications. If someone has received a diagnosis of dementia, there quite often are medications that can help. They don't bring memory back, unfortunately, but their aim is to kind of stagnate that process and that deterioration. We have memory review nurses who repeat the assessments maybe 6 monthly.
We're just laughing at Walter the dog, Walter the puppy, who's just...
He wants to be involved. We have memory review nurses that we can kind of repeat the assessments 6 monthly, 12 monthly, and we generally just kind of keep an eye on people. We try not to be, too intrusive. And what I say to people is, the less we see you, the better, really, because we want you plodding along at home. But, just so people know that we are kind of in the background, really. The point in doing the memory retests is we use, obviously, each assessment. The first assessment we do is the baseline, and then the retests that we do from that we can compare and we can look back and see if there has been a deterioration. We have care support workers that work in our team who can help people engage in social activities, because quite often that's a big thing. If someone's received a diagnosis, people tend to they can tend to kind of isolate themselves or label themselves as, well, I can't do this or I can't do that, or quite often the people are just kind of at home, as I said, especially now with COVID. A lot of the people's social routines have stopped and they're not able to engage in some of the activities that they used to. So our care support workers are able to help people look into social stuff that might be of interest. It could be Men in Sheds, it could be the Live at Home scheme, and we've got numerous day centres, obviously depending on kind of where you live and what you've got access to, but just kind of general well-being stuff, really, to keep people occupied and to make sure that their mood is, their mood is as good as it can be and their quality of life is as good as it can be, really.
Sure. So when I speak to people in my clinic whose lives are affected by dementia, for the most part, it's speaking to family members who are worried, often a spouse who feels like they're carrying a lot and feel quite alone. I think that's a feeling that a lot of people have. They feel quite lonely and like they're carrying quite a weight. Where could you direct these people to who are feeling like they're struggling with their current situation and they're feeling either like they have a lot to carry or they feel quite alone in what's going on?
Of course, that is a big thing. Carer stress is a massive thing, and I always say to people, it's easy for us at the end of the day. We come in, do what we do, and we walk away. But when you're living with someone 24/7, that's a massive burden to hold. I always say to people, you can call us anytime. 642-879. If your relative is known to us, I'll be your Mona nanny. Ring, let me know what's going on, and if we can help, we will do. And there are kind of carers groups and things out there. Some of them informally. We do have decafs, what we call the Dementia Cafe. So I am based down in the south of the island, and our decaf is the second Wednesday of every month, 2 till 4, down at Port St Mary Golf Pavilion. So basically that's an informal chat and a cup of tea with the person who's been diagnosed, the person with the memory problem or dementia, and their carer, friend or relative. Quite often we have staff from OPMS down there, ourselves, and we have Admiral nurses as well. But basically the Admiral nurses can offer kind of post-diagnostic support and support for the person with the diagnosis. We've got the Alzheimer's Society as well, who can offer, you know, support for families and the individual who's being diagnosed. But what quite often I direct people to as well is in terms of access and resources in the community, is the integrated hubs, the wellbeing partnerships. So as I said, I'm based down south. So we've got the Southern Wellbeing Partnership down south, which is based in Tyrosian, Old Southlands. And basically they're a kind of single point of access for most services, and they kind of know what the crack is, really, what's going on, you know, what people can get access to. So they're a good point of contact.
Yes, definitely. We're really lucky to have the wellbeing partnerships. I think we've got a north, a south, and a west now, haven't we?
Yeah. So we've got the west was the first one. The west was the first one to get up and running, and they're based down at it's kind of where the Corin Home was, the day centre down there. Obviously, the southern one is kind of up and running now. The northern one's going to be up and running soon. And the west, I think, will be, because obviously there's quite a lot of GP practices to incorporate in that.
The eastern one.
The eastern one, sorry, yeah, the eastern one. But yeah, no, we are really, really lucky to have that. As I said, just that single point of contact for services, because quite often, as you say, it is people feeling completely overwhelmed by their situation. And quite often it's just letting people know what resources are out there, you know, and that there is things that, you know, some things may not fit everyone, but there are things out there that may be of help, you know, and we want people to know that there are people there ready to help if needed.
So the wellbeing partnership groups, if you're someone who is struggling with dementia, either for yourself or within your home, you can approach your local wellbeing partnership to look at what different agencies can become involved in your case and improve your life, right?
Yeah, absolutely. You know, and as part of our assessment process as well, if the person with the diagnosis has come through our service, which obviously quite often they will, you know, we try and we'll try as part of our assessment to signpost people. We'll try and signpost people to the relevant services as we feel fit and necessary, really. But yeah, you know, there are, depending on what the person's needs are, there are care agencies out there. As I said, there are those kind of third sector, you know, men in sheds and live at home and befrienders and things like that. There is support for carers and family members, that kind of post-diagnostic support, that period, maybe of just receiving a diagnosis or maybe just having it confirmed, because quite often people do know, you know, and just kind of having that cemented really can be quite like, right, okay, this is what we're dealing with. So yeah, they will have access to those, as you say, different agencies that may be able to offer support.
I think pretty much everyone has some sort of experience of dementia, whether with a family member, a close family member, or a neighbour. And sometimes when we look right back, you know, decades ago to care that was received, it can be a really part of the worry of seeking help and a diagnosis.
Absolutely.
What would you say to people who, recognising in themselves that actually either they themselves are really struggling with memory problems or their loved one is, but they feel really frightened about approaching services?
Of course, and this is a big thing. It's one of the biggest barriers that I have to try and overcome as a professional, you know, building those relationships with people. What I'd say first and foremost is we're not that scary. We're not that scary. We're not, you know, we're not big monsters that could kind of come and scoop you up and take you away from who you love and what you love and, you know, your current situation. The reason why we do what we do is to keep people living at home as independently as they can for as long as they can. Times are very different now. Ballymona doesn't exist. You know, there are necessary services, you know, if people need more support. But we try and keep people at home for as long as we can, you know. And what I always say to people, because it quite often does happen where, you know, people will, because even just that first step of going to the GP is a massive thing, because it's having to admit that, yeah, there is something wrong, you know. And as you say, quite often people's experiences are informed by, oh, well, my mother, you know, in the 80s was taken away into a home, and things are different now. Times are very different. Number one, we don't have the space in homes to put people in, you know. as I said, we want to keep people at home. That's what we want to do. So it is a big step, you know, as I said, going to the GP in the first instance and admitting that there is a problem is a massive thing. And I always say to people, you know, I'd rather us be able to do something about it than in, you know, 3-4 months, years, whatever it might be, things become unmanageable. And, you know, hindsight's a wonderful thing sometimes. As I said, you know, we're not that scary, and it is hard when you have to kind of admit that there is something wrong. It kind of makes it all real, doesn't it? You know, people often will just bury their head in the sand and say, no, she's fine, it's just a water infection, or no, it's just an off day. You know, unfortunately, sometimes when those off days become a bit more frequent, it's scary and it's difficult to manage, you know, and especially seeing that change in a loved one is a really difficult thing to have to go through. You know, but we are there to help. And, you know, the less we see of people, the better, really. We just want to kind of bob in, do what we need to do, make sure people have got what they need, and then leave people be.
So your primary goal is to allow people to be as independent as much as they can and have the best quality of life as they can, whilst making their own life choices.
Absolutely. And obviously sometimes there does become a time where people do think they can still do the washing and still do the cooking, and it's like, I'm sorry, my love, that's, you know, not anymore. And, you know, we do step in at the relevant points to make decisions on people's behalf if it's deemed necessary. You know, but if someone wants to stay at home because they've lived in their home for 50 years and that's where all their memories are, then we don't want to take that away. You know, we want to make sure that we just put the scaffolding in place to make sure that they, you know, they can carry on doing what they do.
How do you think that we can destigmatise dementia?
Obviously talking about it helps, you know, and people sharing their experiences. And I do think that's becoming more, you know, people will say, oh, my nana had dementia, or, oh, yeah, my granddad, or, oh, I remember this. I think, just people talking about their experiences of if they've been through the memory clinic process, or they've been through the process of getting a diagnosis, talking to people about it. You know, obviously there was that, did you ever watch that TV programme that was on? I can't remember what it was called now, but it was basically people who've been diagnosed with dementia, younger people in their, you know, 50s, 60s, kind of early 70s, who were maybe still in part-time work or still kind of engaging in whether it was charity work or like I said, part-time jobs. And the whole point in that was to try and show people that just because you've received a diagnosis doesn't make you incapable, you know. It's like with the driving, is people think, oh, well, you know, if they're still driving, or well, if I receive a diagnosis of dementia, I can't drive anymore. In some cases, that may be the case, but actually not in all cases. You know, I had a lady who came through memory clinic relatively recently who received a diagnosis, and actually she's doing quite well in her, you know, she doesn't drive far, family have got no concerns. We have to report it to the DVLA, but it doesn't necessarily mean you can't drive anymore. You know, so I think just kind of, people being more open about their experiences of living with it. And talking about, you know...
Yeah.
Sorry.
No, it's okay. I'm just watching the dog take the opportunity to completely trash the toys there. You know, it's really interesting talking to Emily about what she does within her role, because within my role, speaking to people who are really concerned about approaching dementia services because they're frightened of what the future holds, and they're frightened of a loss of control. They're frightened of that feeling of losing their mind, that actually it's quite the opposite, and that approaching dementia services means optimising your well-being and keeping you as independent and in control for as long as possible. So it's actually the very opposite of the fear that so many people have. And it's really interesting talking to Emily because she's young and vibrant and really excited about the role that she's doing. And this is exactly where she saw her career going as a trainee nurse. And it's lovely to see someone with such a passion in long-term health. Emily, how do you work with the idea that the people who you are caring for are not going to recover from their long-term condition?
That's the hard part. That is the hard part, is knowing that, you know, unfortunately the nature of what dementia is, it's awful, you know, it's not a very nice illness, but what I like to think, well, what helps me is knowing that, well, hoping that my involvement with someone's, you know, that really difficult period in someone's life kind of makes the best of it, you know. It's not nice, and ultimately we know what's coming, but I want to make sure that people have a great time, you know, and have the best quality of life that they can have. Just because you've got dementia doesn't mean that you can't do things, doesn't mean you can't, you know, can't carry on doing the things you love, can't have a great quality of life, can't go out and talk to people and engage with people, you know. I absolutely love what I do, you know. As you said, I've always wanted to do older persons from when I was a student, you know. I've just always had a real passion for it, and just knowing that, well, hoping that what I can do can just make that little bit of difference, or even just make the person's experience of going through memory clinic a little bit more positive. Because you say it isn't nice, and it's a very scary thing to go through, you know. I hope that the kind of personal experiences that I've had with dementia in my family, I can relate to people with that. And as you say, look, most people, probably all people, do have an experience with dementia, whether it's a loved one, a relative, a neighbour, you know, so just using that to kind of connect with people and try and support people through that process. You know, I would hope that's what kind of makes a difference in my role.
So Emily and I were talking before about how the diagnosis and the experience of dementia for the patient and the family is a really big thing, and it's not something that any of us want to go through. And the purpose of this conversation was not to minimise anyone's experience. We totally can see what a big deal a diagnosis like this is.
Absolutely.
But more to really highlight how people's experiences can be improved and optimised, and people's wishes be taken account of, and that there's loads of things that we can do within a difficult time to improve the experience. Is that how you think of your role as well?
Absolutely. And as you say, we don't aim to just brush it off as, you know, another thing that goes on someone's past medical history. It is a massive thing. It's a completely life-changing thing. And what I find, you know, for a lot of people is, if they've lived quite independently, all of a sudden have to either rely on other people or let other people in, even just having other professionals in your home asking these stupid questions about what day it is or who Harry Barnes is, you know, is quite a difficult thing to get over. But, you know, I as I said, I think just hopefully our involvement in that person's, you know, in that person's process through memory clinic kind of improves people's experience, and addressing the stigma as well. You know, as you said, it's people don't get better from it, but that, as I said, that doesn't mean to say they can't live a fulfilling life, you know. And eventually there does become a point where maybe the person can't engage actively in the memory assessments anymore, you know, when their kind of physical needs increase, and they do need a lot more help and support with that. You know, so then it's about how we just help families adjust to that, because it is a massive thing, you know, that whole lifestyle change of letting people in and accepting more support, and even just living with the idea of dementia. You know, it's that thing that it's like cancer. Everyone hears it. It's everywhere. You know, it's all over the newspapers. It's all over the you know, the radio, on the telly. We think, well, it's never going to happen to me. But unfortunately it does. It's becoming, I think, more prevalent because people are living longer, which is a great thing. Yeah. You know, so it's just saying, do you know what? It happens. It does happen. It's life-changing. But hopefully we can kind of help change things for the better as well.
You navigate it in the most positive way possible.
Yeah, we try to.
You know, Emily's great because you can really hear from listening to her, can't you, that she's very enthusiastic. You know, she can just me and Emily talked for hours really, and it was difficult to pull out the bits of the conversation to put in the show, but she's so passionate about what she does within older persons' mental health, and it's really lovely to chat to someone that wants to shout it from the rooftops and get her information out there, if you like.
Hi, I'm Rebekah Traynor and I'm a speech and language therapist, working now as an independent practitioner. I've previously worked for Manx Care in the adult speech and language therapy team. My passion as a speech and language therapist is all about improving communication to change lives. Dementia can impact on a person's ability to talk, and this can impact on many parts of the individual's life and can also affect people close to them as well. Communication is so key to all aspects of our life, from asking for a simple request for a drink to meeting with friends for a meal. The loss of verbal communication can feel devastating, but it is important to remember that communication is not just about talking, but as adults who have talked since we were small can lose track of the other ways to communicate. Even if a person has lost the ability to talk, it doesn't mean they don't want to tell their own story. It doesn't mean they don't want to request a drink. But how can we plan for this or be a supportive conversation partner? So I've got a few ideas to share with you today that I know have worked in my years of working as a speech and language therapist. One of the key things I feel as verbal communication is lost or reduced is joint attention. This is something to use that you both know that you are talking about, so it focuses the conversation. This could be getting a family photo out, could be the local newspaper, it could be old photos or a calendar. You can then use this to support the conversation. You can ask questions, you can point, you can comment. When you are tuned into the conversation and the joint attention, this makes communication so much easier. Plan for the future. This is key. Create a life storybook. A life storybook is basically you telling your story through pictures, through simple phrases, and it's a great opportunity for a family member to support somebody in creating this. It gives you time to laugh over old photos of old holidays or times when things have been difficult, or it can be an opportunity to remember key parts of a person's life. Again, this brings in joint attention, that you are letting them tell their story non-verbally, verbally, any form, and writing it down for them. I've had a recent experience of how this has enabled a person with dementia to go to a class and tell their story using the pictures that we had put together. Another tip is non-verbal communication. It's really important to remember that 50 to 80% of our communication is non-verbal. We need to be good at looking at people's facial expressions. Maybe they use a gesture such as pointing for an item that they would like. We could use objects to sort of support a request, maybe showing several tops that they could wear in the day and getting them to choose them. Using non-verbal when the verbal word has gone is so supportive. We often rely so much on verbal content that as adults we miss the little additional clues that show us what that person might be wanting. I think it's really important to recognise when a person loses their verbal communication, they still do want to communicate. It's part of us as a human. We, as conversational partners or family members who are struggling with this change, need to give this person, the individual, a means to communicate. We need to also give them the opportunity. This might take a little bit more time. It might take a bit of imagination, but it also means that we can ensure people can be included and maintain their confidence in communication. And it also allows us as a family member or a conversational partner to still be involved with that person we love so much. This isn't always easy, and I've often had my challenges with this. And it's not easy to change a habit of a lifetime. We're always reliant on talking. But if we recognise it early and support it early, it can be the key to allowing this person to continue to communicate in many, many different ways, and therefore continue their confidence, continue their social interaction, and to always be part of family conversations.
So I'm very lucky that I got to speak to some families who have been affected by dementia.
Yes.
We're going to listen to them now.
Hi, my name's Rosie, and I'm here just to talk a little bit about my mum and living with Alzheimer's. Her name's Jan. She'll introduce herself now.
Hi, I'm Jan, Rosie's mum. I nearly said daughter. The worst thing for me was when I found out that my mum had got memory loss.
Yeah.
And I knew my granny had had it earlier, but it didn't pose any particular problems for me or my mum, because granny was easygoing. Then my mum developed it when I was still visiting her at least 3-4 times a day. And I tried to get my mum diagnosed, and she wouldn't have it, wouldn't go.
Yeah.
And finally, I think when she was taken in for an operation on her legs, it was discovered then that she got worse, and she was officially rubber stamped, diagnosed.
And then discharged. She didn't manage really at home after that, did she?
No, she didn't manage well, and she got a little bit more aggressive, but that's because I brought her home to my house, and she didn't recognise it at all. But we finally got her settled somewhere, settled in
home. So do you think your experience with
home, that experience
impacted?
Well, it impacted, but it also helped me later on in life to recognise something before you become kind of not rubber stamped, but before you.
Yeah, you took control of your own diagnosis a bit, didn't you?
My mum was in denial all the time, all the time,
never have,
and I watched out for mine, thinking, "Don't come, please don't come, please don't come." But I'm absolutely fine. I still drive.
Yeah.
I've got
your full-time carer for your husband, your dad.
So you still have a good life, a brilliant life. It's just that you've got to know your limitations. That's what I would say.
Yeah, very good, very wise.
Being the age that we are, we've got appointments now and again.
How old are you now?
71.
Yeah.
And Alan's 74.
Yeah, so like remembering appointments or what?
Remembering appointments is quite an issue for me. So you have to have a system of telling somebody else, writing it down the minute you get the appointment, so you don't forget.
Yeah.
Because once you've not written it down, you forget you've even got an appointment, let alone what day the appointment is.
So you've got like a little notice board, haven't you, up in the house?
That's my lovely daughter that set that up for me. Who is on the other side of this interview.
So that does help, doesn't it? I was going to say, you also normally screenshot things on your phone, and you often send them to me, so it's like so other people are remembering them on your behalf as well.
Yeah, so it's acknowledging where your limitations lie and doing something about it that's proactive. So I send on information I've been sent, such as appointments. I can't think of anything else, but because my husband's got his own particular ailments, which are physical more than anything else, and he's paralysed from the neck after a car accident. But
do you think having those long-term care responsibilities for Dad and that routine that you had with Dad sort of kept you going initially after the diagnosis? After mine, it's a devastating diagnosis, isn't
after
it?
Mine, I carry on.
You got up every morning and still, did the morning routine, looking after Dad. And
I refused to give up my.
You've always maintained
my
that
home job, which is to look after my husband.
Because you've always led a healthy lifestyle, haven't you? You've never smoked, not drunk much alcohol at all, always been outdoors, been physically active. So
done yoga.
We were quite shocked, really, when you got it, but then we don't know whether genetic factors influence it or anything else. And do you remember how you felt when you were first diagnosed to now? Have you changed your perspective on it?
Now, to tell you the truth, I can't remember whether I've changed my perspective on it or not. But I remember the word is hard to swallow.
Yeah, when somebody says it,
you've got different forms of it.
Yeah.
But once I'd actually outed, as it were.
And accepted it,
once I'd come out and I began to tell people. And I realised that half of them couldn't give a toss, because if they're your friends already, they just go with it.
Yeah.
And they say, oh, don't worry about it, you'll be fine.
Yeah.
Which actually means nothing in reality, but it means there's no offence taken on their part.
Yeah.
You know, so you just crack on with it. And lots of people are more than happy to help me remember stuff.
And do you take medication for it? You do, don't you?
I do. Now, the problem with that is making sure that you
remember to take
it.
Yeah, and you also use like the Alexa, don't you, sometimes?
I use that
if
a
you
lot.
need to set an alarm or something to and for your to take your medication, you have like a little prompt on that.
Yeah.
And do you think that's helped the medication?
Oh yeah, definitely.
I do as well. Me and my dad and other people around you do feel like that's definitely helped stabilise. And one thing you did this year, which was a lovely thing to do, was that you were my birth partner for my giving birth to my child, which was wonderful. So in that sense, having a diagnosis of Alzheimer's doesn't necessarily mean you can't do the things you want to do and tick off all of these big milestones in your life still. I mean, COVID hit the year after your diagnosis, which must have been difficult, having to stay in through lockdown and not being able to go outside and go on trips and things.
I got a bit down because my diagnosis had come through then. But at the end of the day, I'm probably more chilled than I've ever been. Probably. Because I haven't got that capacity to keep on worrying about something over and over again.
So you don't think too much into the future with it? No.
I don't see any point in that.
No. But it's something I've always thought, supporting you with Alzheimer's or being your daughter, that I would want to do things within your wishes. So we did have some frank conversations, I think, a few years ago after your diagnosis. And we've not really revisited them because I've not felt the need, really. Because things are quite stable.
I used to garden a lot because we had a garden nursery and we used to sell to the public.
You still do that, don't you?
I still garden, but I tend not to sow new stuff. I tend to just
maintain things that are there.
Old stuff that repeats itself.
Yeah, like building new skills and learning new skills is apparently one of the things that a lot of people with Alzheimer's can't do.
Yeah.
Although I have to say, I persuaded Mum to get an iPhone, didn't I, a couple of years ago after your diagnosis, because I've got one, and it just means we could share information and you didn't want to because it was a new phone, and you have mastered it, and some of it might be fluke. I'll get a text message on one platform like text messaging, and then I'll get a reply on WhatsApp or Facebook.
The other thing about that is I've forgotten it now. That's the first time I've forgotten.
Yeah, if you don't get your words out or somebody doesn't let you.
On time. I was waiting for you to finish because to butt in.
Yeah.
Sometimes if you've Alzheimer's, you need to butt in with somebody because if you don't, and you don't know how to do it, you don't know whether to be rude and say, shush, I've got something to say. And if you do that, that emotion that goes with it often blanks out the thing you wanted to get across.
With Mum having it, what I've noticed about, I've gone through some grieving process myself, which I've grieved parts of my mum that I feel have kind of slipped away sort of slowly over time, but I've still got to hear, and I've also gained a different mum, and it's like a living grief. But if my mum accepts it and adjusts, then I kind of try and follow suit and adjust, and you do.
I don't grieve now.
No.
I don't think I'd grieve at all now. And I don't think I'm as frustrated as I used to be.
Yeah.
And I also need other people more than I needed them before. For instance, I sometimes forget how to put the telly on because we've got one of those tellies that does everything, lets you watch films, lets you do this, that and the other. And unfortunately, we got that around about the same time I started to lose my memory. But it's brilliant because instead I get the carers that come in to look after my husband, I get them to set it all up for me. Tell me where the off button is, and off I'm away.
Yeah.
I must get this across, that you don't lose things like how to drive. You just do not forget how to drive.
And you've not lost sort of the familiarity of people around you and your family and friends at all, have you?
Yeah.
You have sort of stabilised.
Yeah.
Because some at advanced stages, well, sometimes obviously people wouldn't recollect family members and things, which can be really difficult.
Occasionally I'll forget we've got carers in to look after my husband, and occasionally I'll think, my God, I've been talking to him for 9 months and I know his name, but I can't think what it is. And then I go, oh, ding, he's called T. You get used to that, and it becomes not an important thing in your life.
You don't dwell on it. You just live in the moment, don't you? I've noticed. You don't dwell on the negative things, and you're just happy in the moment.
I think I'm happier than I was.
I think you're happier than you were.
Yeah.
In it, yeah.
Because it's taken away my ability to go over something
to
again
dwell
and again,
yeah,
to dwell.
Yeah, that's very true. Yeah, it's almost a little bit mindful in that you just in the here and now.
Yeah. Appreciate every minute that you can while you have it.
That was really interesting to hear, I suppose, that angle of dementia.
I think it's really great that we have been able to talk to someone who is living with dementia and able to give their own perspective on how dementia impacts them. It's not often you get to hear the perspective from someone who has dementia. So, from the show, what are your biggest take-homes?
Well, we have a few questions from listeners here, Ciara, that I was going to put to you. We'll do the quick fire round. So first question from a first listener here is, does everyone eventually get dementia, Ciara?
No. So there definitely are predisposing factors. Lifestyle is the biggest one. So you are more at risk of having dementia if you have been a smoker and you've got quite a big smoking history. And you're less at risk of having dementia if you do plenty of active exercise, for example. But unfortunately, that doesn't mean you'll never get it. But they're two examples. I do know that there's been a recent Kentucky study, going to slide this in there because I can't stop talking about the menopause. But women who take lifelong HRT are 73% less likely to have Alzheimer's. And I think that's huge.
That is huge. Another question that has come in here, and actually we've had several themes along this line. Does everybody who gets dementia end up in a nursing home?
Also, no. If a nursing home is an option for anyone who chooses to go there, and for some people it's perfect. They know that they're well taken care of. They know that they don't have to overly rely on family and friends. And they know they won't be lonely because there'll be other people to talk to. So it's a perfect option for some people. For some people, it's a necessity. But for many people, there is so much support available now to help people stay in their homes for as long as possible. And, talking to Emily there, that was exactly what she was describing. Her job is to help people to be independent and live in their own home the way that they want to for as long as they want to. It's really important that people have the conversations about their wishes and also that we listen to people's wishes because they might change too.
Well, that's interesting because that's another common question that's come in is, if I'm worried that my mother or father has dementia, should I tell them?
Oh, I don't know. What do you think?
So I think, so what I think there's absolutely no harm in telling them and having that conversation with them and saying, look, I'm noticed that your memory isn't great, that there's been a few, I suppose, examples of your memory maybe not being as sharp as it used to be. Have you noticed that? And if they say no, then that's useful in itself. And then the second thing is, how we pop down to the GP and have a conversation with the GP together. And I think that's really helpful.
I think for a lot of people who have dementia, there's fear there, and there's fear of being judged and not supported. And perhaps if you're able to say, listen, I'm here for you and this is a safe space, that's really important.
Ciara, that was our programme this week, which was on dementia. What are your take-home messages from this week's programme?
This week's programme has reminded me to get out there and exercise a bit more, for sure. And also that there is so much more to dementia than just a decline. I think we've heard some quite inspiring messages, and I think it's a condition that you live with, and that you can definitely put things in place for to have the best experience possible. How about you?
So for me, actually, it's interesting, and it would be to have a conversation with your loved one, and that may be your husband, your wife, or your father and mother, about this idea, the concept of an enduring power of attorney. So basically start the conversation, mom, dad, or my beloved wife or husband. What happened? What would you like to happen if your memory was to get worse? And to put those structures in place, because actually, you know, we think that's something that'll never happen to me, but actually it happens to lots of us. And to have had that conversation and to have the structures in place for that, if your memory does start to fail, that there are plans in place in terms of what we're going to do in terms of accessing the finances and all those things. It's a really boring thing to talk about, but actually it makes the world of a difference if it happens.
Absolutely.
And I suppose another positive point, as always, is that basically do everything in moderation. So it's okay to have, you know, 1 glass of wine, but not 100. You know, smoking is never okay. A bit of exercise and a balanced diet is the best way to live your life. So, Ciara, next week, what are we talking about?
Next week, we're going to talk about teen health.
That's going to be a difficult topic.
Yes, we are still deliberating quite what that's going to look like, hey?
Because it's very broad and it's very difficult to know what to bring up.
They've definitely got some unique challenges.
They do. And if there are particular questions that you have, either about yourself, if you're a teenager listening at 6:30 p.m. on a Thursday, or if you have a child you're worried about, if you could send them in to us at bodywise@manxradio.com, that would be helpful for myself and Ciara to decide what exactly we're going to cover teen health wise. And other than that, tune in to the podcast on manxradio.com for a fuller length interview with some of our guests and some more content.
Yes, do.
And next week, as I said, we'll be talking about teen health. So tune in to us then. Thank you very much.
Thanks very much for having us.
Good evening and good night.